Welcome, everyone. I am Lauren Gates. I am your host of this Airway Health Solutions special conversation featuring Dr. Mike DeLuke. Welcome, Dr. Luke. I am thrilled to have you here.
Thanks, Lauren. Happy to be here.
Yeah, and I'm so excited for this conversation because the topic is the current state of the airway movement, and it's an orthodontist perspective. And you gave this presentation on the Palooza stage, and it was like a mic drop. I mean, it was really a moment, and I just wanted to bring this moment to life and really spread it across, basically the globe because we are international, and just have everyone hear your perspective on where we are in the airway health movement. So thank you for bringing this to life once again. I'm actually excited to see it again and also to learn new things. It's never stagnant. So thank you for always keeping it present and interesting and enthralling. Everyone will love this. But we're also excited to have a raffle at the end. So stay to the end to give away a free intro to airway course. And I'm going to do a formal biography. But before I do that, I want to see who's with us tonight. So let's go ahead and take a poll and see who's joining us, all the different collaborators. And let's see where we're at this evening. I think the hygienist won the last one, but let's see who wins this time. I was hoping we get more orthodontists tonight too. So let's see where we're at that. Okay, 9%. We're getting there. One just dropped out. It's 8%.
They're like, I'm out.
Sorry, Mike, didn't even say anything yet.
Don't want to identify with it.
So let's see. Okay, we have 55. Let's take a look and see. Okay, so it's our usual suspects here this evening, a little bit more with the orthodontists, but welcome everyone. We love your enthusiasm and thank you for being part of our airway health movement. Again, we have close to 600 registered this evening, so we will have the recordings, and this will be on YouTube also, so you can share Dr. DeLuke's insights with people in your area. I love this to be spread all around to all the orthodontist students, anyone who's airway curious. This will be a nice, basically, collateral for you to have to do a lunch and learn. So just a few disclaimers and housekeeping items. The views presented are the opinions of our speaker and are not necessarily affiliated with Lauren Gates and Associates and Airway Health Solutions. And the following webinar is provided for educational and informational purposes only and does not constitute providing medical advice or professional services. The information provided should not be used for diagnosing or treating a health problem or disease, and those seeking personal medical with a licensed physician or dentist. Always seek the advice of your doctor or other qualified health provider regarding a medical or dental condition. And then also to receive your CE, we're really glad to provide this free for you this evening. You do need to be present for the entire presentation, and we will automatically track that with our CE Zoom attendance. So you don't need a code, you don't need to submit anything, but just give us about a week to get you that certificate. And so now without further ado, I want to introduce Dr. Mike DeLuke. Dr. Mike DeLuke is a board certified orthodontist who received his DDS from SUNY Stony Brook and completed the master's in dental science and specialty training in orthodontics at UConn, where he served as chief resident in his final year. He owned and operated DeLuke Orthodontics in Schenectady, New York, for almost 2 decades before retiring from private practice to teach and coach full-time. He has served as a faculty member at several hospitals and orthodontic residencies, including as a cleft craniofacial orthodontist at Albany Medical Center. He is currently a faculty in the Department of Orthodontics at Montefiore Einstein Hospital in Bronx, New York, and the Pediatric Dental Residency at Healthcare New York in Naples, Florida. Dr. DeLuke launched Dr. DeLuke Orthodontic Coaching, or DOC, in 2023, and is the creator and host of the incredible DOC podcast, which I highly recommend everyone listen to because you get to educate us from so many different realms. So thank you so much for joining us, and I'm really excited to see this presentation and to really have a great discussion after. So the floor is yours.
Well, thanks so much, Lauren. Always a pleasure to be with you and the Airway Health Solutions crew. And I really appreciate the opportunity to come on and share this again with some of the guests, as well as with many new guests. And as you said, this goes around the world. And for those of you on the YouTube channel that see it after, share this. We want to get this message out to everybody. And as you alluded to as well, I am looking forward to the discussion and the question and answer afterward. That is a lot of times some of the most fun that we have. So, all right. So let's, I'll just go over the learning objectives in the beginning here to make sure everybody understands a little bit more what we're going to talk about. Lauren did a great job prefacing it, but I'm going to highlight the general sentiment of the orthodontic profession and orthodontist towards those who take an airway-focused approach to patient care. We're going to describe the evolution of this mentality. We'll examine the role of evidence basis in this debate. And I actually added something new into this talk. That is, I was telling Lauren ahead of time just this week, some hot off the press takes that we'll throw in and you'll see. Gain an understanding of why many orthodontists are opposed to early airway focused treatment. And then we're going to discuss a strategy for the future to close up. Nothing to disclose as far as any relevant financial relationships with any products or people represented herein. So what I want to do is look at this from a perspective of time, a chronological perspective of the past, the present, and the future. And interestingly, I'm actually going to start with the present. I want to start on the present here and show a little bit about where we currently are, just to give everybody a little context and paint a little color to what this looks like from the inside for an orthodontist. Because I know there's a lot of perceptions of how people think this is what's happening in the profession. So these are the main societies that the American Association of Orthodontics has many regional societies that meet separately, independently, in the fall every year. So these were the 2025 fall meetings. And what I did, I literally went through every single one of them and looked at all the lectures. There were over 100 lectures given combined. And the number of lectures that were on airway-focused early orthodontic treatment, total, two. Two lectures. Now, you might ask, well, what were they talking about at these meetings? And they're like not just a day meeting. Many of them are 2, sometimes even 3 days of lectures. Lots of things that are on practice management, marketing, efficiency. Nothing wrong with any of these topics. I ran a practice for almost 20 years. As Lauren said, I was very focused on being hyper efficient and effective, having a really strong team, being a good leader. That's all great. We also need to back it up with some of the more clinical early treatment, proactive, whole patient based orthodontic treatment or airway focused orthodontic treatment as well. And this isn't just a fluke. And you might say, well, Mike, maybe just pick the year they didn't do it. I've actually applied multiple times to speak about pediatric sleep disordered breathing to the American Association of Orthodontists for multiple of their meetings and have been told that they feel my topic lacks interest and relevance, and they're concerned I'm going to promote indiscriminate expansion. And those are quotes. Now, you might say, well, what is indiscriminate expansion? It's kind of orthodontic speak for expansion in the absence of a crossbite, because many orthodontists think you should never expand in the absence of a crossbite, as many of you are aware. Not all orthodontists, thankfully, but many do. And many of our academic institutions and the academic establishment, as well as organized orthodontics, tends to view that. Now, some of you may have seen this wonderful article in June of 2025 in the American Journal of Orthodontics and Dentofacial Orthopedics. And I'll just show you a couple of the quotes from this article. When you look at the title, it might not be possible to tell what exactly the gentleman who wrote it was trying to convey. Until you look at some of the quotes, a causal relationship between respiratory behavior and dental facial growth cannot be drawn. You can't reliably determine if mouth breathing is a thing. Yes, that's a direct quote. Can we change patients with a long face to a short face? The simple answer is no. What exactly qualifies as an unfavorable tongue position? And lack of any knowledge of the tongue and what it does. Humans only need to slightly open their mouths to breathe orally without any extreme posturing. And this one isn't a quote, but just a summary statement. The author neglects to acknowledge the neurocognitive, cardiovascular, and or behavioral implications of mouth breathing or pediatric sleep disordered breathing, never addressed throughout the entire editorial. And that's an important word, editorial. The gentleman says, I was asked to write this editorial, which means the editor of the AJODO personally asked him to write this article saying that mouth breathing isn't a thing. And we need to really just calm down about all this mouth breathing stuff. So that's where our organized establishment is at, academia and the AAO. What are everyday wet finger orthodontists saying about this topic? Well, like many things, if you want to know what's going on, right? Go to social media. I'm going to call this segment a little fun on Facebook. So these are actual posts I'm going to show you. I've redacted the names, the last names, because there's no point in pointing fingers at any particular people. But I want you to see that it's real. And these are the things that we see all the time on social media. And these are our orthodontic only groups. So here's some pictures and a radiograph. What would you do? Female, 7 years old. Chief complaint. Our general dentist thinks she needs ortho treatment. No, parentheses, little, space for lateral incisors. 6-12-month recall. Start phase 1. Posting, Ceph bandage, roll pics. Thanks. The first comment was observation 6, then 12 months, and consider RME then. For now, I'd leave this child alone. Now, again, many of us may find that interesting because we know, I'm sure many of you looking at it, I mean, not only does, I mean, the fact that he doesn't have room or, she doesn't have room for those upper front teeth really is the symptom, as I call it. The teeth are the symptom. The narrow arches are the etiology. And so we see this narrow V-shaped arch, this high vaulted palate, insufficient tongue space, the lower left lateral, which is, again, what they were concerned about is the eruption of the teeth. Notice there's no pictures of the patient's face, right? We don't see the patient's face. Even the ones that I didn't click on were more intraoral and the cephalometric radiograph because we're not looking for it. And what did this gentleman say? We're just going to highlight part of it. I'd begin with considering serial extraction guidance of eruption. At this age, I'd extract C's and maintain space while monitoring dental somatic growth and development. I do not see the need to begin expansion on a 7-year-old. Period. If, big 2-letter word, you are thinking expansion, wait until such time as the child is a bit older and more mature. And this goes on all the time in our groups. To try to combat that, I wrote a couple articles for Orthotown. Orthotown is a really wide circulation. It's read by a lot of people. It's not behind a paywall, so you can send it out you put it on your website, you can send it out to people. And it gets seen and it gets read. I actually got a lot of comments from people on this. But some of the people in the social media groups were not so happy. So it was a 2-part series I wrote. The first one, you kind of see the picture up here. I was discussed what pediatric sleep disorder breathing is. And then in the second one, I talked about how we can detect it and address it in our young patients. One gentleman said, the ambiguity of your comments and articles is unfortunately used by even less trained personnel to promote this dangerous proposition. Now, literally, I was talking about recognizing airway problems in young kids and addressing them. And I called dangerous because when relative language is used, it opens the gates for any such claim. At this point, we could call it pseudoscience, but unfortunately in dentistry, airway has passed that threshold, and now we are dealing with charlatanism. That is dangerous and affects negatively our specialty. This is another post that came up. Many dentists are recommending to correct anterior crossbite on a 2-year-old using expander mild braces and referring to trained cranial osteopath. Saw this discussion in another Facebook dental group. This is so concerning. How can we stop this kind of thinking besides commenting to the post to wait and watch, keeping this post anonymous to avoid any controversy? One person said, we can't stop it, but we can try to embarrass it. Call it out for the bullshit it is. Excuse my language. Educate families to recognize the money grab it is. And you can see that is a lot of likes. Usually a comment to a post, and these will not get that many likes. That's an extreme number, the high number of likes. Another person said, these days, when I have a new patient's parent tell me, our dentist said you might want to treat this insert treatment modality, expander's the biggest one I get, I nod, smile, and then I tell the parents that people need to stay in their lanes. I don't tell dentists how to do crowns. Dentists don't get to tell me how to do orthodontic treatment. I'm not ugly about it, just very matter of fact. And then this lady commented, I agree to another. It was something that Tamara had commented on, and this Iona was commenting back saying, I agree that applying knowledge and science works. That is why we study to become specialists. The rest of you, and I think she means it's just pseudoscience and pure lack of ethics. Lack of ethics. Think about that. Like pseudoscience isn't bad enough. They're questioning our ethics for doing this type of thing, for treating kids younger than they may be able to or be aware of. Here's an example of a post that I thought I would shed a positive light on. It was someone who posted talking about the team at Stanford that was doing some amazing things, guiding the craniofacial growth and development of a young child with Pierrot sequence. So I decided to chime in and say, thank you for posting. Such a great example of how we normalize anatomy to redirect craniofacial growth and development in children. When you normalize tongue position, orofacial musculature, and nasal breathing, all children will grow better. And that is well documented in both the ortho and medical literature. This is the type of proactive approach we need to adopt as a profession versus waiting until the patient grows into a severe malocclusion and trying to put the pieces together. Don't think there's much very controversial about that. Probably most people in this group are thinking, yeah, of course. Well, it was not met with fanfare. This gentleman said patients with craniofacial syndromes and cleft palate should not have their treatments used as justification for treatments for patients without these syndromes. Again, if they're growing abnormally, does it matter if they have a label or not? Do we have to wait until they have a cleft or PRO sequence? It makes no sense. As a side note, as those making these unproven extra treatments seem to always head there, I believe that it does need to be pointed out that there is no research, as in zero, to support the notion that intraoral tongue space, in quotes, has any relationship to OSA or SDB. So I responded, regarding your comment, I believe it does need to be pointed out that there is no research, as in zero, to support the notion that intraoral tongue space has any relationship to OSA or SDB. Zero research, really? And I decided to provide a few articles to show that. And this was the response. Someday, when I'm totally bored and have the time to once again waste my time reading your nonsense and debunking your poor logic, maybe there will be time for your arguments. In the meantime, let's just agree to disagree. I will maintain my belief that you are a complete charlatan, duping those who pay for your services. You may think of me what you wish. My best. Someone else posted, you can't reason with someone who promotes orthotropics. And he replied, in my opinion, a disgrace to our profession and a scourge to our patients. Every field has its quacks, outliers, and those it's just ashamed of. In my opinion, here is one example. Interesting comments, right? All because I said that was all in response to me saying we should go in young and try to help our patients grow better and breathe better. This is the sort of venom and vitriol. We're going to talk shortly about why this is, or why I feel this is, but it's pretty intense. It's really pretty intense what's going on. And to underscore that point, a little teaser I said in the beginning, I just recently, within the past few days, this article was published in OrthoTown. I would love you all to see it. Lauren, we can maybe find a way to put a link up afterwards for everyone. I can direct them to see the article. I didn't see this post myself, but a friend saw it and sent it to me and was upset that it was there. And the response from this person was, when the dumb lead the blind, yet another vomit-inducing collection of thoughtless drivel produced by this aspiring quack. I suppose it's easier to concoct monologues of bullshittery to fool the mentally deficient than it is to actually practice clinical orthodontics. Again, interesting take on it all. And all I was doing was talking about the fact that orthodontics lacks a lot of evidence basis. It doesn't. We'll talk a bit more about that in a minute. I was just calling out the facts and the data. I want to play for you a short video that just will highlight some of the, I guess we can call it arrogance, we could call it ignorance, of the orthodontic world when it comes to some of the problems that our patients who suffer from sleep disordered breathing face.
Zach, what's your take?
My take, airway orthodontics is the essential oil of orthodontics, of dentistry.
Of the whole field.
Yeah,
so what do you mean by essential oils and all that? What do you mean?
I mean, I walk into dental offices, hygienists want to talk airway. They've been to a course. Dentists go to courses and they want to talk airways. And it's like airways, the new buzzword of things we can fix without much scientific backing of we can really do much for it. I mean,
yeah, fair enough. And so it's sort of like rubbing a little bit of like eucalyptus oil on the underside of your earlobe. It's going to help you with your sciatica.
Yeah. Oregano oil really helps with indigestion.
I think one thing that cracks me up is you'll see people who do airway orthodontics are trying to justify the efforts and everything, justify the essential oils, as it were, per your take. And they'll show like a before CBCT and an after CBCT. Here's a 9-year-old, here's a 14-year-old. Shocker, the airway has grown. Puberty is an amazing drug, right?
Growth and puberty can help a lot with changing your anatomy. You know, I do say, hey, we expand a lot. I'm pro expansion. I do expand a lot, but I'm not making promises they're going to stop pissing the bed.
Yeah, that is a funny one. Is I hear a lot of like connection to bedwetting.
Yeah,
and I don't know.
I mean, there's
go ahead.
Well, there's other reasons the bed could be wet, but that has nothing to do with airway.
It has something to do with puberty.
Cut that part.
Yeah.
Lovely, right? Yeah. So kind of when we were having the technical difficulties, you already saw the slide of how I feel and how you may feel about this. I mean, it does really incite rage because it's just we know those poor kids are suffering, and the fact that as healthcare providers we're marginalizing that and laughing about it. So I did comment on that, trust me, and it turned in quite a battle. Sadly, I don't think maybe one person came to my aid. Everybody else was just heaping it on. I'm overreacting, and so. Again, I continue to fight the fight on this, but it's sad that not many other people are willing to speak up. So we're getting there. We are making some progress. The other thing it makes me angry. I don't know about you. Like, I mean, I get like, I want to fight back against these people. And I made the mistake early on of doing that, not physically like this. Although we weren't behind computer screens, it might have been a chance of that at points. But emotionally fighting back and with words, verbally fighting back. And I was a little, I think, aggressive in that initially because I was just so offended by all of these comments being made to me. And I realized that we're really better off when we practice something called tactical empathy, which is when we understand the feelings and mindset of another so you can increase your influence in all the moments that follow. And I just want you to think about that for a second. Tactical empathy. So we're trying to increase our influence, but we're doing it through understanding the feelings and mindset of another. Well, how did we get to this point? And that's important. If we're going to understand their mindset, how did this happen? How did this happen that they are this opposed to what we do and the way we practice? So take a little trip down memory lane here. Here's a quote some of you may have heard. Of all the causes of malocclusion, excuse me, mouth breathing is the most potent, constant, and most varied in its results. This is not a new quote. That was from Edward Engel in 1907, the founder of modern day orthodontics, well over 100 years ago. So the concept that the way we breathe impacts the way the face grows and the way the teeth meet is not, or erupt, or don't, as the case may be, is not new. In fact, I want to highlight this. This was Dr. Ketchum was a DDS who gave this at the meeting of the American Laryngological, Rhinological, and Otological Society in Philadelphia in 1912. Now, as a little aside, how cool that a dentist was speaking at this medical meeting back then. We need to get back to that, and I am working on trying to make some inroads with the medical community to do just that. But I want to highlight part of it, and for me to read this so you can kind of hear a little bit more about what's being said. But it's my purpose to show how the orthodontist may overcome abnormal forces, how he may interrupt the progress of the abnormal formation of the bones and tissues of the jaws, the face, and the nasal cavity, as well as the accessory sinuses. How normal forces may then be made to act so that abnormal development may give way to normal development, and the poorly developed mouth breather, who is usually backward mentally as well as physically, may be induced to develop along physiological lines. 1912, we understood this. And here are some highlights. I actually put this up in the doc community on Facebook a little while back, and I'll mention that a little more at the end if people aren't in that and want to join in that. But this was from 1922, a physician, Dr. Samuel Adams Cohen. And I'll just highlight 2 points in it. One was that nasal breathing is vital for correct oral development and is one of the surest preventions of irregularity of temporary teeth. And another one was the treatment of malocclusion should begin as early as possible, 30 months of age being considered the most favorable time. The younger the person, the more plastic the tissues. How did we get from there to where we are today? We're going to talk about that. Dr. Ricketts, Robert Ricketts, legend in the orthodontic field, but not uncontroversial. He was a very controversial gentleman because he pushed the envelope and he made people uncomfortable in that way. And he said the functional balance and stability of orthodontic results have seemed to be enhanced by removal of respiratory obstructions and the attainment of normal nasal breathing and correct patterns of deglutition. 1968 in the American Journal of Orthodontics, which is now the AJODO. That name switched in 1986. Kind of ironic that it was more about DO, dental facial orthopedics, before they changed the name. Again, we'll talk about that in a second as well. But we've talked about this. This isn't new in our profession. Subtelny ran the program at Rochester for, my gosh, probably 40 years. He was the director of the ortho program there. The Harvold studies, most of you are aware of the Harvold studies. And then in the orthodontic literature, this is in 83, they were doing studies on mouth breathing in allergic children and how it was changing the way our face grows. So why all of a sudden did it change? And if we think of the attitude toward airway focused interceptive treatment as a bit of a pendulum, we had this sort of pre-1990, when you look at the literature, era where it really was open-minded. And I just showed a few examples. I could literally take all 45 minutes and show you examples. And then we have this closed-minded approach that you saw before that when I was showing you the present. Well, if we want to figure out what could have caused this shift, I do have some ideas. There's a gentleman, Orhan Tunke. I do not know him, and I don't blame him for everything. I'm not heaping it on his shoulders. Just in the amount of time we have, there's only so many examples to cite. But this is a pretty big one. In 1993, in the now AJODO, and he was a well-known guy. He was chairman of the Universities of Kentucky, Mississippi, and Temple in their ortho programs. He founded two big journals, Orthodontics and Craniofacial Research and Progress in Orthodontics. So he's not a lightweight in the orthodontic world. And this article, he basically created kind of a, a dichotomy of like good and bad orthodontists, right? There's the good guys, and they focus on accepted orthodox orthodontic care. They treat based on research and education. Now we have the bad guys who are practitioners of alternative unorthodox orthodontics. He refers to them, you may have seen these words recently, as charlatans and quacks. And he calls out those who perform proactive early treatment, especially as being in this group of charlatans and quacks. It's kind of the focus of the article, actually. That's a lot, right? And this is our leading journal, and you get someone out there saying this. This has pretty significant ramifications and a ripple effect through the profession. We have Tony Gianelli, brilliant guy, literally had a photographic memory of the literature. I mean, like nothing I've ever seen before. He was absolutely brilliant. He was the chair of the orthodontic department at BU for ages. Not in like an old school extractionist type of guy either. He was really pretty progressive a lot of times in trying to avoid extraction. But what's interesting is he had a lot of articles that talked about how you didn't need 2 phases of treatment to do it. You could avoid extractor. You could make room for the teeth. He used a lot of E-arches and holding arches, and he didn't get into the mechanics in these articles, but he's kind of questioning those who are doing this sort of 2-phase approach. And I'll just highlight a couple bullet points on each one to give you an idea of what's in them. This first one from 1995. For greater than 90% of patients, essentially all treatment goals can be accomplished in 1 phase when started in the late mixed dentition. Added cost of early treatment outweighs the limited benefit. The second article in 03 concluded that expansion in the absence of crossbite is not appropriate, and instead we should try to solve tooth size, arch size discrepancies in the mixed dentition by maintaining E-space. He was really big on maintaining E-space. I never understood that, even in my residency. I'm like, but the problem isn't because they need to preserve E-space. It's not like the E's that are the cause of the crowding. It's not. Why are we robbing the E-space, which then leads to greater impaction of your lower second molars, especially because you're not letting them migrate forward mesally as needs to happen for the second molars to erupt. That's why that myth gets out there that phase 1 treatment causes greater impaction of second molars. It's when you're hung up on trying to maintain E-space. But if you notice, these articles focus solely on the teeth. They don't say anything about airway or patient health. It's a total tooth discussion, which is not the same thing. We can have an argument and a debate about whether or not you need early treatment to fit all the teeth in, even without extraction. That debate is incomplete unless we also talk about the impact that airway and overall patient health and craniofacial growth and development play in this discussion. The tough part is that many orthodontists and many people in my field use these articles to claim that proactive airway-focused ortho treatment is not evidence-based. I am sure a couple of you out there have heard that claim being made, a claim that I refuted in that article that I showed earlier. But what is evidence-based practice? I'm going to give you just 5 seconds, 10 seconds. Just think about that. Think of a definition of it in your head. What is it? It's actually, Sackett called it a triangular epistemology. It was a philosophy of three concepts, a confluence when they came together, created evidence-based practice. And it was your clinical judgment and expertise. It was relevant scientific evidence. That's the data, right? The research. And it was the patient's values and preferences. And that was where he said the confluence of those three areas is where evidence-based practice exists. You need all three. And notice, one circle is not larger than the other. They are equal in weight. And the interesting thing is, in this article he wrote in 96 in the British Medical Journal, Sackett, again, the founder of evidence-based medicine, said that it is not restricted to randomized trials and meta-analyses. Not restricted. If no RCT has been carried out for a patient's predicament, he said we must follow the trail to the next best external evidence and work from there. That's an important point. Follow the trail to the next best external evidence. He didn't say wait for an RCT to be performed. Oh, that's what some people say today. They say you need that relevant scientific evidence. And that is what matters. The other parts are not important. And without the relevant scientific evidence, you should not be performing a particular procedure. But that is not what evidence-based practice is. Even if it were, though, let's play a little game here. Is everything that orthodontists do backed by RCTs? Because they're saying that unless we have randomized controlled trials, I literally just saw it in a post today, unless we have randomized controlled trials on this, they're interestingly, they're shifting a little bit. They're calling it the data, right? Because I've actually done, I'll say I've been fairly effective at kind of refuting this whole RCT argument. So now they're kind of saying like, we need more data, right? But let's just say, is it backed by RCTs? Well, let's take a couple things that we all know about. Class 1 occlusion. Don't think you'd find an orthodontist out there who doesn't try to achieve class 1 occlusion in their patients if and when possible. I'm guilty of it. I'm super perfectionist orthodontist. Something I always strive for in my patients. But is it based on randomized controlled trials? There's actually an absence of randomized controlled trials to demonstrate it is superior in terms of functional outcome, stability, TMJ health, or long-term oral health. And it is based on clinical tradition, expert consensus, and observational studies. Yet we do it all the time and don't ask for additional research therein. What about cephalometric measurements? I mean, this is a big one, right? I mean, look, this patient's got a lower incisor mandibular plane angle of 114. I mean, we should really extract on that patient and bring those teeth back to get them to be like 90, 95 degrees, right? Because that's what the studies that came out in the 50s and 60s and 70s told us we needed to do. So those must have been based on randomized controlled trials on hard data, right? All observational, case control, and retrospective analyses. It stems from studies on normative data done in the mid-1990s by Tweed and Steiner. That's it. So you have people basing their entire treatment plan on Ceph numbers that are literally based on observational case control and retrospective analyses. I am not saying Ceph numbers are irrelevant. I use them. You need to use them for certain parameters. But let's not kid ourselves that they're backed by randomized controlled trials. Age to initiate treatment, big one, right? There's got to be an age. I mean, AAO says by the age of 7, which they don't say wait until 7. They do not say that. They say no later than 7. But there's no concrete evidence of a universal age to begin ortho treatment. And all the research is solely focused on teeth and occlusion, not overall health, airway, neurocognitive, and behavioral, et cetera. In other words, they're looking at, when they look at an age to start, the debate is like those articles I was showing you. Can we fit the teeth in if we wait? Or even if we can't fit the teeth in and we extract, can we line the teeth up and give them a nice class 1 occlusion with good measurements on the Ceph and an aesthetic smile, however that is judged, because that can be subjective, if we wait? They're not looking deeper at the patient health and the comorbidities of sleep disordered breathing. Clear aligners. What about this one? So clear aligners were first launched and came about in the late 90s. It was actually Stanford MBA students that launched it. It didn't come out of the science arena, right? All the orthodontists screaming that you need the science and this is pseudoscience. I mean, this was literally developed by MBA students. The first high-quality randomized controlled trial showing the safety and efficacy of moving teeth with aligners was with Invisalign in 2015. So any orthodontist out there that you know who was moving teeth with plastic, I'm guilty of it. Not again, this is not me pointing fingers at other people. I'm part of this. I just want to expose the hypocrisy. Was moving these teeth and using plastic without any randomized controlled trials showing it was safe or effective to move teeth with plastic. And we still have limited randomized controlled trial data on the predictability of tooth movement with aligners. But we do it all the time. And we're very proud of it. In fact, Dr. Tung K, to return to him, and again, I'm not saying this to heap it on Dr. Tung K. I just think it's a good example of the hypocrisy that exists. This is from his website, the creator of Invisalign. He's not the creator of Invisalign. The creator of Invisalign was Stanford MBA students, so I'm not sure what that's about. But the point I want to make is not that. I want to point out that if he was so proud that he was like one of the first offices to offer Invisalign, as I mentioned just a minute ago, that was the late 1990s. At least a decade and a half before we had any good sound evidence and data that this was an effective and safe way to treat patients. But remember, he's the one who wrote this article. So does that sound like someone who's providing accepted orthodox orthodontic care based on research and education? Or is it someone who is practicing alternative unorthodox orthodontics? And he may be just the very charlatan or quack that he purports others to be. Interesting, the hypocrisy. And I call it out again, not to point fingers or be controversial, but I want to expose the truth. I call balls and strikes on this stuff. I said, I admit I was doing these things. I'm not pointing fingers at my orthodontic colleagues. I'm just looking for consistency. This, again, makes you have the reaction of getting very angry when you see the hypocrisy, right? But remember, we have to practice tactical empathy. We have to be better than that. We can't just go fighting and yelling at them that we're doing it right, you're doing it wrong, or you need to look at it this way, or we have such amazing results with these patients. That may be true, but that is never going to convince them that they need to think differently about this topic. First, to practice that tactical empathy, we need to understand what these obstacles are. What is standing in the way of the average orthodontist? What obstacles are they facing when it comes to providing this proactive, holistic, airway-focused care? And as one who gets to see behind the scenes all the time, I can tell you pretty accurately what they are. The first one, we're going to go through a bunch of them here. Epictetus said, "It is impossible for a man to learn what he thinks he already knows." Very true, right? Remember, we went to school for a lot of years, and we're like, if this was a thing, I would have learned it. I know all there is to know about tooth straightening. I'm a board certified orthodontist. I know what there is to know. It can't be a thing. There's something called the Dunning-Kruger effect. And this is a really cool curve. I love showing this and talking about this. But basically, it talks about the fact that when we have maximum confidence and minimal knowledge, we find ourselves at what they call peak ignorance, meaning we think we are really right on a topic. And this happens to all of us in our lives in different facets. But when it comes to airway and ortho, the orthodontists are really in that peak ignorance place a lot of the times because we think. I just today saw someone post that the orthodontists know more than Stanford sleep physicians about airway and airway health of kids. I literally, they literally posted that. And I'm just like, that is literally the Dunning-Kruger effect, the epitome of it, because that's that confidence gap. When you really understand and learn things, when you get to be an expert, you're never as confident as you were when you didn't know what you didn't know. And so they're in that realm. So just understand that about your colleagues, that they're not coming at it from a place that they're trying to hurt their patients or hurt you. They're really, even the nasty things they say about me, it's just because they're just ignorant to the real realities and the facts when it comes to what this is all about. And part of that is due to the fact that we didn't ever get trained in this stuff. We didn't learn it. We don't learn it still. Not many residencies. I'm working on that with some residencies that and programs that I work with, but we don't learn this by and large. In fact, we get little to no education in our orthodontic residency on the clinical or radiographic signs and symptoms of airway compromise, what even pediatric sleep disorder breathing is, let alone its neurocognitive, cardiovascular, and behavioral comorbidities, and or the treatment of patients less than 10 years of old, especially their behavior management. That's really important to understand. We don't get taught how to treat younger kids. We don't see them. When they come in at a young age, gets beyond the scope of what we can discuss tonight, but the way the orthodontic residencies are set up, when we see them at a younger age, we just recommend that you pull teeth till they're mature enough or ready enough for our treatment. That's why they're not doing a lot of young treatment. They don't know how. Our teachers, the faculty, they don't know how to treat a 6-year-old, 7-year-old, let alone a 4-year-old. That's why they say we shouldn't be doing it, because they don't know how to do it. So they can't teach us. And truthfully, change is difficult, right? I mean, just think about it. Take it out of the realm of even what we're talking about tonight. When you're faced with two choices and one requires you to change and the other requires you to continue in the same habit, we all want to go towards our habits. We all do. We all do. So there's a lot of that, right? Their habits are the way they run their practice and the way they treat patients. And now we're asking them to change this. That is not easy, especially when there's no incentive. What is their incentive to do this differently? Really, like, sincere question. Like, why would they uproot their successful practices and the flow of their day and their systems to do something that they didn't learn how to do anyway and they think isn't a thing? Right? I mean, starts to make a little more sense when you practice tactical empathy and try to get in their heads on this. There's a real fear of liability. I know people personally who have been sued and taken to state boards over this. It's real. People will come for you sometimes on this. And I don't know anyone who has lost those cases. They've all won. But it's no fun to get dragged before a professional board. It's no fun to have to deal with the stress of all of that, or have another doc tell a patient that you're doing something wrong or that's malpractice, and have a patient bring charges against you, even if they're unfounded. And that scares a lot of people. They just don't want the headache. And I hear that from people, sadly, all the time. That's one of the reasons I work so hard to get this information out there, so that people are no longer scared and realize they do have the data on their side. Time, right? Time. We all need a little more of that. But time. I mean, this takes time, and not just time to do it clinically, but time to learn it and understand it and get the additional education. And then they've got to implement it in their practice, right? You have to start doing things like sleep questionnaires and looking at different parts of the patient than you're used to looking at, such as their face in different ways. Instead of seeing these faces and rushing to get in the mouth to look at their teeth, you have to see all those things that all of us see: the dark circles under their eyes, the tired eyes, the Denny Morgan lines, the altered oral posture, right? The chapped lips, the chapped gums, the transverse deficiencies, the vertical growth. You have to look at it differently. And that takes time. You then have to potentially invest in a CBCT and learn how to manage those images. And what do you even do when you see a patient like this and notice the cerebral hypertrophy and the inferior position tongue and not up into the palate with the invagination and the dorsum of the tongue? You have to start to process this, right? Looking at the asymmetrical sinuses. It's a lot more education. Understanding the neck posture changes and the pharyngeal airway changes, and looking into tonsils and adenoids. It's a lot of time to do this and add this into a practice. Remember, these docs are used to looking at a pan and a ceph. Some, unfortunately, not a ceph even, but they're just quick looking at this stuff, looking at the teeth and telling the treatment coordinator, here you go. This is what it's going to be. It's going to be a plan 4 or whatever it is. And they get back to the clinic. Our consultants literally tell us, I know because I had them in my practice, doc, get your butt out of that consult room as quick as possible, because you're either going to say something stupid or you're going to open the door to more questions, and you make your money straightening teeth in the back. That's what we're literally being told. So this is really counterintuitive for orthodontists to want to spend more time in the diagnostics and consult. And when you're in that room, you got a lot of answer to a lot of questions. You have a lot more work to do. You then have to follow that up and have your treatment coordinators or patient coordinators sending this information to refer to an allergist or to an ENT or to a myofunctional therapist. It's, again, a lot more time. The orthodontist can feel essentially like this conductor. They go from this, straightening teeth all day to now trying to train their team differently to understand these concepts, help work with medical colleagues, work with myofunctional therapy and speech colleagues, work with other dental colleagues, right? Referring for releases potentially, or helping with a surgical case that you wouldn't have thought airway for before. You would have just straightened their teeth in an adult. And then the family. If it's a child, you're dealing with the family unit as well. And now they come to you for straight teeth, and you're talking about breathing and airway and sleep and neurocognitive problems and ADHD and bedwetting. It's a lot. And so I just ask you to remember that when we get, and again, I'm someone who's taking a lot of shots from my orthodontic colleagues. I always try to remember where they're coming from, because I used to just get mad and react. And now I'm like, yeah, this took me a lot to do this in practice. It was not easy. And then you get into the big one, money, right? I say often, can anybody convince me that if all of a sudden they started reimbursing $5,000 a case for early treatment, we wouldn't see a heck of a lot more early treatment happening out there and going on with the orthodontic world? Of course we would. Like, let's not kid ourselves. Treatments follow reimbursements. And it just so happens that we don't get reimbursed for our time in diagnostics, right? And we don't get reimbursed for the proactive early treatment to the same extent we do the later treatment. And we lose the benefit if we do use it early. And that's a big problem in the orthodontic field. They're worried about burning the benefits out. So that's the reimbursement side. They also have to invest time in buying new technology, right? They have to invest time in not being in the clinic or they have to invest money because they're not going to be in the clinic as much. So they may not make as much money straightening as many teeth. These are why we have such obstacles and resistance. Hubris, yeah, that's there too. You could see that in some of those early quotes, right? I'm the specialist. I'm the one who understands this. You're not. But rarely, and one of the things I really want to help everybody understand, rarely is it one of these factors. It's a combination of pretty much all of them. And it's a lot. Like, this is really heavy stuff for someone to deal with when they're just trying to make a living. And perhaps one of the biggest examples of this, I'm going to let Stacy Whitman, she was on my podcast a little while back. Some of you may know Stacy. She's awesome. Gotten to know her well since this time. And I'll let her explain kind of her journey that she went on. She's a pediatric dentist, but she went on a similar journey where she didn't think airway and now she was all in understanding it. Just want to let you hear it in her words.
It's hard to accept that you've been miseducated or misguided by your industry, your mentors, your institution, and also no one's intending to do harm, but potentially we are. And so it's really hard to look in the mirror and say the way I used to practice was maybe harming my patient.
Yeah,
now,
so true.
I think it takes a unique personality to admit that to oneself. That doesn't feel good. I look back at some of the things I did in my diagnoses and my over treatment and the way I treated patients and like, you need to stop breastfeeding because it's causing decay, to this new mom. Terrible. I'm embarrassed. I'm shamed by it, but it's just part of learning. Like, we're forever learning and evolving.
Forever learning and evolving. Now, think about if one of those patients, you're embarrassed by how you approach the case. And if you're an orthodontist even, and you maybe pulled teeth on that patient and you didn't think airway, what if it's one of your family members? Remember, we treat our families. That's my wife and my two girls. I've treated all of them. What if you've pulled teeth on these family members and missed it, and your kids ended up on ADHD meds, and they ended up with addiction issues? How do you reconcile that? You probably don't. You probably just keep saying it's not a thing, and you probably tell anybody who's doing it that they're a charlatan and a quack and it's pseudoscience. So to wrap up, where do we go from here? Well, now that we understand, and from a tactile empathy standpoint, why this is happening, it does help us. It helps us to understand the psychology of this. Now, Peter Attia, unfortunately, for any of you watching the news, has not had the best press lately, but his book is a great book, and he talks about the concepts of medicine 1.0, 2.0, and 3.0. And what he says is medicine 1.0 is like Hippocrates, bloodletting, when they didn't really know what they were doing. There was really no science involved. It was all clinical judgment. And then medicine 2.0 is kind of modern day medicine, right? It started in the 1900s, and it was very treatment based, antibiotics and medications and treating disease. And he calls on medicine to go to 3.0, which is proactive, whole patient care that doesn't wait for the patient to get sick until they treat them, but proactively tries to prevent the patient from getting sick. And so when I read this book a couple of years ago, I said, we're the same crossroads in orthodontics. We are the tooth-focused approach of this argument over like extraction or non-extraction or early treatment and non-early treatment or starting treatment too soon, phase one, not phase one. That's 2.0. It's a proactive mentality. We're just treating teeth. And I'm pushing the profession. I've actually written some articles. I can send you some more of these as well, Lauren. That we need to get to a 3.0 mentality, right? Proactive, holistic, patient-centered, not waiting for these malocclusions to develop and trying to be the best tooth straightener out there, but trying to get at them earlier before they get to that point. But that requires a paradigm shift. That doesn't just happen. That is not like change your bracket prescription. That is not like, ooh, go from even brackets to aligners, right? That's not a paradigm shift. That's a technique shift. Paradigm shift is literally changing your way of thinking from one way to another. And to highlight that example, and you saw this at Airway-Palooza will know, but if you don't know, this gentleman is Dick Fosbury. And some of you may have heard of something called the Fosbury flop. This is not Dick Fosbury. This was how the high jump was competed, or how the technique in the high jump, which was like a scissor kick. You'd go up kind of legs first and kind of put your legs up and go over and then roll over the bar. He couldn't do it. Dick was this kind of awkward, gangly guy, and he couldn't get his body under control to do it. So he proposed in the 60s that you go over the bar backwards. He was mocked, ridiculed, laughed at, until this picture in 1968, when he set the Olympic record at 7 feet, 4.5 inches, doing the now known as Fosbury flop, going over the bar backward. He literally inverted. He went 180 degrees from the previous technique. And history tells the story of the success because at the 2024 Olympics, literally every single athlete competed doing the Fosbury flop, including Yaroslava, who's shown here, who set the world record. And I just love this picture because she's just soaring over that bar with a technique that 50 plus years earlier, 55 years earlier, was viewed as essentially, was mocked, and he was viewed as a charlatan for proposing it. So it's important to understand that is what a paradigm shift is, and that's what we're going for. We're not just trying to convince our ortho colleagues they should believe us. We're not trying to tell them, this is about extraction, non-extraction. All those things are relevant. They play in. This is about a different philosophy to patient care. So we need to keep going. We can't quit. We have to keep working at this. And I just want to show you some examples of the fact that it is working, right? Kind of maybe depressed you a little bit in the beginning with some of those comments. Let's show you some of and I don't show these, I said this when I was on stage as well, I don't show these to pat myself on the back or build my ego up about it. I show you because I don't want to just make it like it's all negative. I wanted to show you there's actually a lot of people that are starting to come around. Couple examples. Hi, Dr. DeLuke. First, wanted to thank you for the knowledge and experience you're bringing to our orthodontic profession. I've enjoyed reading your articles and listening to your podcast, and I really appreciate the time and effort you're putting into these. Been practicing as an orthodontist in the Charlotte area for 2 years now, and I'm wanting to learn more about helping patients with PSDB. Unfortunately, as I know you're aware, there's a huge stigma surrounding this treatment. I'm looking for a good mentor while I work to provide the best care possible for my patients. While establishing a good Class 1 occlusion is important, there are many other systemic issues that we need to pay attention to, right? That is what we're going for. I spoke up in Georgia this fall, and this is an orthodontist who sent me this picture from his son, and his son is sending this to him and his associate. Sorry for the convoluted context there, but he saw this girl, and he proudly sent his dad, and his partner started 2 airway cases this afternoon. This one is 6 years old. This was the week after hearing me speak because he started to notice the eyes and the face. And his dad said, this is just in from my son, Ryan. You had some influence on him. Patrick at the bottom is our third doc who was out of town when you were here. We need to keep going. Hi, Michael. I'm an orthodontist in Wisconsin. Love your podcast, learning about early orthodontic treatment. I struggle with young patients without any permanent teeth and need expansion. Do you have any recommendations for expanders in primary dentition? And what labs can we use for them? This is an orthodontist asking about expanding in the primary dentition. And went on to say, good job ignoring the haters and continuing trying to educate. All my young orthodontist friends are big fans of yours. I generally think a big generational shift, right? Paradigm shift from 2.0 to 3.0 is happening in ortho, and this is the way of the future. This was posted in the doc community by an orthodontist. He didn't mind me sharing his name. And he posted a case, and he literally said, another case, patient is 3 years old, 1 month, hard to sit still. Mom says he mouth breathes, had adenoids shaved. What would you do? Didn't take CBCT, very hard to take photos, so sorry they aren't perfect. In myofunctional therapy now. An orthodontist, not afraid to post pictures of a 3-year-old asking if they should start to treat. And this is the new one. I said I'd tease something new in the beginning. I just got this today. Great podcast. This was referencing a recent podcast that was put out with, I think he was talking about the one with Brett Christensen. So I love how everything tied together, including removable expander potential remodeling to MARPI, true skeletal expansion. You guys are pioneers for us GPs. Keep it tracking forwards and upwards. People are recognizing it and people are jumping behind. It's happening. We're getting there. It's not easy. It's a grind. But this approach I've been taking of tactical empathy and being less combative and just starting to put data, put evidence, put research out there, put knowledge out there has been working. So I just want to finish up with a video for everybody.
Finally, in SEAL training, there's a bell. A brass bell that hangs in the center of the compound for all the students to see. All you have to do to quit is ring the bell. Ring the bell, and you no longer have to wake up at 5 o'clock. Ring the bell, and you no longer have to be in the freezing cold swims. Ring the bell, and you no longer have to do the runs, the obstacle course, the PT, and you no longer have to endure the hardships of training. All you have to do is ring the bell to get out. If you want to change the world, don't ever, ever ring the bell.
Don't ring the bell. I know it's not easy. I know. I saw the list of people who are out there. It's people in every part of this discipline, from hygienists to assistants to myofunctional therapists to dentists, orthodontists, pediatric dentists. I know it's not easy. Trust me. I'm on the front lines of this battle, but don't ring the bell. Don't stop. Too many patients are counting on you. And I showed you before, this was the pendulum we had before, right? Open-minded pre-1990, closed-minded post-1990. If we don't ring the bell and we fight for this and we keep pushing for what we know is best for our patients, we are going to flip that pendulum back. And after 2025, starting now in 2026 and beyond, we need to have a different mentality that is pervasive in the field of dentistry writ large about how we approach patient care. Thank you.
That's amazing. Thank you so much. And the inspiration behind this is incredible. And I actually loved your story. We actually did a conversation on your story of how you got to where you are, how you moved through tactical empathy. But can you just give us a reminder for those who didn't see that episode of how are you this unicorn, Dr. DeLuke? Like, how did you overcome the 8 hurdles that you mentioned and now get through the other side? And now it's like, there is no bell. What bell? There is no bell to ring.
Right. But I can't see a bell. Not
Right.
even on my radar.
Exactly.
Right. Well said. It's a great question. It's funny. History, you always kind of, when you look back on things, the mind's an amazing protector, right? It kind of makes things, it's the kind of the old time heals all wounds, right? And it was not easy. I fought, I lost team members over this, changing my approach. I lost referrals in my practice because of this. I thank God I had about 6 years in my community, 7 years before I started doing this. And I had built a reputation of being really good at what I did as a tooth straightener. And I'm really fortunate for that. I'm really fortunate I was blessed to be a really, really good tooth straightener. So people knew I knew how to do clinical orthodontics really well. So it wasn't like they were like, oh, well, he can't hack it in real ortho, right? But I did experience all of that pain, and I did experience the challenge. I guess the best way to answer the question, Lauren, is I knew deep down, because I was seeing what it was doing to my patients, that something was happening. And I had a lot of things in my favor as well. I was my own boss. I was a solo practitioner. One thing I didn't get into as much, just in the interest of time, but I can mention it now. A lot of these docs, they're not top of the totem pole, or they're working for a corporate. They can't just go in and tell them you have to shift the paradigm to Ortho 3.0. They might have a senior doc who's like, absolutely not. They might have a senior doc who's still pulling teeth, and they have all they can do to just be like, we don't need to pull teeth as often. So I had the good fortune that it was my practice. I ran it. I owned it. No one could tell me what to do. When I wanted to put a low-dose CBCT in and pay almost $200,000, which is what they cost in 2014, I could do that. And that is a luxury that I don't take lightly, because it helps to also builds my empathy for people who work for someone else and they don't want to take the time. So it was hard. It was a journey. It was really not easy. But then once I started, I would say, I always tell people it was about 1 to 2 years of a real dogfight, of really trying to get people to understand what I was doing. And then after that, the results just started to speak for themselves. And then I had ENT sending me patients and allergists sending me patients. I mean, this is 10 years ago. This is before this was even really talked about at scale like it is now. And then parents would be calling, like, we heard that Dr. Mike looks at things differently. We heard he understands how to look at airway, and I think my child's not breathing right. And it just started to take off. I didn't market it. I didn't advertise it. I was fortunate that I had a reputation. I didn't have to advertise because my practice was very strong. So people just started talking. And this was really before social media was a big thing. I mean, this is 2014, 2015. It was not what it is now, for sure. So that then just started to reaffirm to me that, okay, I'm on the right path. I'm on the right track. This is the right thing. You'd only need 1 or 2 kids to start breaking down, or parents to cry and give you a big hug because you've changed their child's life and they can now go to a sleepover because they're not wetting the bed anymore, before you start to say there's more to life than just giving people straight teeth. And so, and I guess at my core, I am a fighter. Literally, I mean, I was very competitive in boxing for a long time. I like a challenge, and I just kind of have it in me that I want to stand up for those that can't stand up for themselves. And that's why I'm not afraid of any of these people that say these things about me. I'm fighting for the kids. I'm fighting for the docs that you saw some of those messages at the end. And I'm blessed that I have many more that come to me to be like, I got you. Like, follow me. We're not going to back down from these people, and we're going to bombard them with facts and data and evidence. And we're not going to relent.
It's amazing. And like the Fazberry flop, it's like the DeLuke dip, I'm going to call it, right? Where you just kind of like go in a paradigm shift. Can you give start where you are, use what you have. Can you give an example of someone who's curious about this, especially the orthodontist? I know the general dentist too, but what's like one call to action that you could give someone to get rolling on this, at least start to change that? Because it can be overwhelming when you beautifully laid out the 8 obstacles, and it's not an easy path, but it's certainly a rewarding one.
Yeah. The first thing is that, again, it takes time. You've got to do your homework. You've got to start to understand this. It's not about an appliance. And we talk about this on my show all the time. It's not about just putting an appliance in. I was just telling you, Marion was on the show, and she was saying the episode will come out tomorrow. It's not about like promoting like one appliance or one technique. That's, I think, what gets us in a lot of trouble in this movement. And now I'm not saying there aren't certain appliances or certain techniques that work really well. Those are different thing. You have to educate yourself on the science. You have to understand what pediatric sleep disordered breathing is. I am working very hard to get that message out, because if you don't understand it and you just try to like treat airway, well, what are your parameters? What are you treating? And that, I see what the orthodontists say. That opens it up to a lot of criticism, even if it's an orthodontist doing it for another orthodontist. Like, what are you doing? You're just expanding people to like cure their breathing. Well, yes, that might be a part of it, but we have to understand the diagnostics that go into this and not jump to the treatment. So again, education, so you understand the diagnostics. That is key. I really believe, Lauren, once you start to understand the diagnostics, it gets easier to fight to do this and implement this, because you can't then unsee it. And you're like, oh my gosh, like the text I showed you from my colleague whose son, like once he saw it in person in that, I was a 2-hour lecture I gave up in Atlanta, Georgia. That was all it took for him to be like, whoa, I got to look at my patients differently. So he put the time into the diagnostics. So again, doing your homework and educating yourself, and not focusing on the treatment or the end result first. Focus on the etiology and the diagnostics first. And then you can start to learn ways to approach it and treat it.
Great advice. Who are your mentors?
Within the field or outside of the field?
You can get whatever you feel is relevant. It's all
So
relevant, right?
right.
Let's
Interestingly,
start with in the field first, and then
in
you
the
can
field,
throw
I would
in.
say one
Yeah.
guy who I've never probably said this publicly on it is Jim Chauvin. No one, I don't know if anyone would know Jim.
Okay.
Really mild mannered, understated guy. He was in my town and he gave me my start. I never worked for anybody, but he owned a practice and he was a satellite office, was in the town I'm from in upstate New York, where I wanted to go back and practice. And he let me sublet space from him out of his orthodontic office as a young orthodontist, the days he wasn't in that office. And so I didn't have to buy chairs, equipment. I bought my own, obviously, wires and brackets and stuff, but like the hard assets, that saved me so much money in the beginning. And that's why I was able to hang a shingle and start. And you know what I admired about him? He's the one who taught me about a Herbst. And yes, I understand we can have debate on Herbst, whether, pushes the maxilla back and all, but it still can be, when used, it can be very effective for, let's face it, mandibular advancement devices that they're wearing at night are Herbsts, right? We understand that. So it's certainly better than a headgear effect. And he got kind of ostracized from the orthodontic community where we were practicing because he was pushing the envelope on not extracting teeth. He was doing phase one. He was, and I never, it's so funny, Lauren, back then, I didn't understand the politics of this. Like, I just knew like he didn't hang out with all the other older orthodontists in town. Like, I knew like Jim just kind of kept himself and did his own thing. But he was so good to me and he was so confident in who he was, and he didn't apologize for the way he was treating. And I had never done a Herbst in my residency. And I didn't know because we were taught you pull teeth. You have a class 2 with a retrognathic mandible. You pull up or buys or give him a headgear. I mean, that's what we were taught. He was one to help me be like, no, we can help bring the lower jaw forward. And he helped me figure out the designs for it, sharing this openly with me when I was literally like a competitor of his. Like, I was this young guy starting in the practice. So I always really admired that. So he was a mentor, and I turned to him throughout my practice career. Interestingly, a mentor who has passed, kind of my biggest life mentor who does tie into the profession, is my grandfather, my late grandfather. He sadly passed in the mid-90s before I was still in college. But he was an oral surgeon who literally built kind of an empire in dentistry, and had a group practice back in the 1950s before there was like group practices. They weren't a thing. And he was an oral surgeon. All 4 of his boys, my dad being one of them, became dentists and oral surgeons. And in the 3rd generation that I'm in, my 2 younger cousins, one's an oral surgeon and one's an endodontist. So he really, he broke down a lot of walls between dentists and physicians. Back then, dentists weren't allowed in the hospitals. You weren't allowed to get credentials in a hospital as a dentist, even as an oral surgeon. So he broke down those walls. They kept the dentists out of the staff rooms, the physician staff room. They wouldn't let him in, and he fought to get in. So that fighter instinct, to not back down and to not be afraid to fight and stand up, for what's right. And he did an amazing amount of good and gave so much to so many people. I mean, I would have patients come in to see me, and their grandparent would bring them in and like, your grandfather, oh my gosh, I had a toothache one Saturday night and he was I called him and he said, come on over, so just that caring for your patients and caring for the community and trying to do bigger and better things than just your profession and your sort of skill, came from him.
Well, he'd certainly be proud of you paying it forward and the message you're spreading. Can you tell us about your doc podcast? And do you have like a link or something I can do
Yes,
in
I
the
can
follow-up?
put
Because this is such a great resource. And a lot of these questions you cover in your podcast. Like when you're saying to educate yourself, you make it so easy because it's entertaining and there's so many different perspectives. And I would say just watch all of the podcasts, watch our archive. Also, it's all free. And then just get on the ball. But how can people find you on the Doc podcast?
Yeah, thank you. If you scan the QR code there, it will take you to
Oh wait,
all of
you're
the
not
content.
sharing. You're not sharing.
I stopped
Sorry,
sharing. Let's see.
yeah.
Is there now?
Yep, there we go. Perfect.
Okay. If you scan the QR code there, it will take you to all the different avenues that you can find me at. YouTube, it's at The Ortho Coach, the Doc Podcast. Most people, my bulk of my audience is on Spotify and Apple. I don't know if you saw, Lauren, like I got some like crazy awards from Spotify in 2025 that were like top 1% of certain things, top 5% of all podcasts. Yeah, it's done. The show has really grown. It's humbling. It's been so much fun, and I love having the conversations I have. Yeah, it's really there. Actually, my wife just found, she searched, there was one podcast rating, and it was the #1 orthodontic podcast at this point. So yeah, it's grown a lot, and we're at tomorrow episode. Miriam's 143, so
Wonderful. Yeah, Dr.
yeah.
Motlow, she's on our faculty now, Dr. Miriam Motlow. So I'm really
Yes.
excited. And Dr. Britt Christensen was just on. You've had all of our faculty on. So it's
Yeah.
really, there's so much to learn. And what I love about it is how you humanize everything. Everyone, walks a path that's not easy.
Mhm.
Everyone's carving their own path. And this community is so special that every voice matters. And even just helping one child, one adult, live their life healthier, everything matters. So you just bring it down to the lowest common denominator many times, and really appreciative of your work. So thanks again, and make sure everyone gets these resources. But there are some questions too.
Sure.
That I want to do, and it's kind of like a trick question, so I'm going to give it to you in the spirit that it comes in, I guess.
Okay.
Is how do you determine when airway focused treatment is truly indicated versus traditional orthodontics?
Diagnostics. I mean, it's a great question, and I don't mean to answer it so simply to not give it the attention it deserves. But diagnostics. That's why I was saying before in response to Lauren, it's not just about the treatment, and it's about the diagnosis. So when you look at a patient, I'll take this as an example. Patient comes in. I saw this in the residency not that long ago. Patient comes in, and they have really broad arches, kind of spacing, like a 7-8-year-old kid, spacing, broad arch, plenty of tongue space, right? No real significant malocclusion. But because you've done your diagnostics, you're still always checking if this patient has an airway problem. Well, they fill out a PSQ, and we find out they're snoring, they're mouth breathing, they're having ADHD-like symptoms, and all these other issues. The resident, I actually could hear this the resident doing the diagnosis, because I was in a bay right nearby, and I was really proud of the fact they were going through all this. And I was convinced, because I couldn't see the teeth at this point of the face, that I was going to walk over there and see. A lot of us are probably thinking in our heads what we would see, right? Narrow arches, high vaulted palate, insufficient tongue space. But I didn't. I already said I saw these broad arches, and I'm like, okay, like, this patient, I'm not going to expand this patient. Expansion is not what this patient needs. Where am I going to move things? Like, the lower molars were up right over the bone, or really wide intermolar width, and plenty of tongue space. Like, we need, and this was a battle in that program of getting CBCTs. We need a CBCT. We need to work with allergy. We need ENT involved. Something is causing this patient to not be able to breathe through her nose. And that's why I have a hard time with people who just say, like, expand everybody just because it's airway. That's harmful, I feel, to the overall movement, because then you're just doing the same thing on the opposite side. Like, you still need to diagnose these patients. And if you can detect these problems, now that's we had that same patient, right? Just to kind of full circle answer that question. And it was what I thought I was going to see. And I walked over. I still would have wanted to see the nasal passageways and the pharyngeal airway. And I still might have been working with the EMT, and Mayo as well could be in there, right? And she had a lip habit, so we want to get Mayo involved. So we could still potentially have those accessory providers involved. But now I'm going in, and I'm going to help her grow better to normalize her craniofacial, intraoral, and skeletal anatomy, right? So could have the same presenting symptoms, but based on what I diagnose as being the anatomy that I can impact, I can only play a role in it to a certain extent. Jeff Rouse, who's on my show, he said he calls it normalizing anatomy. Our job is to normalize anatomy. It's not to make it like abnormal or freakish, like make some patient's maxilla 75 millimeters just to keep trying to get them to breathe properly, right? We all hear that. We're like, yeah, that's ridiculous. Well, then how do we know when to stop, right? Well, you have to, normalize the anatomy. And that's why I'm a huge fan of CBCT. Oh my gosh. It's really hard to understand what you're looking at without it. It really is. So that would be another big thing. How do you know? You've got to have CBCT and understand how to read it.
And then how do you collaborate with sleep doctors and ENTs? Can you give a little bit more insight on that, and maybe a little advice as well?
Yeah, that can be really hard. It can. I was blessed. I was the orthodontist on a cleft craniofacial team. So I had a great network of ENTs and speech providers. And then I have, I wouldn't say I'm blessed on this part, but I'm a allergy sufferer myself. So I had relationships with allergists as well. And so I was fortunate in that regard. I didn't honestly know how fortunate until I started going out and teaching this and realizing what a problem this is for people. There are some remote options that you can work with. There was a guy on my show, Avi Bar. He was on a few episodes ago. I have no financial ties to anything he does, but he does like a remote virtual sort of sleep assessment where they mail you a product. They can kind of monitor your sleep. I think he's down to age maybe 12 with that now is the lowest, but I think they can do it younger, but it's like kind of like, where the FDA approval is at for it. But there's some remote options for that. And you're just going to have to beat down some doors. I just had a conversation with a colleague of mine 2 days ago, and she was like, she was going to meet, so would have been last night. She went and spoke in front of a group of pediatricians because she's trying to develop networking with her medical providers because she's just hitting a lot of walls. She said her words were, there are no ENTs in this area who even want to see these patients young. Mm-hmm. It's hard. It's hard. So It's a challenge, but that's why one of my missions for this coming year and in future years is to start to do a better job of educating our medical colleagues because they don't understand this either. And a few of the guests I've had on my show in the past 2 months have been sleep physicians, and they're the first ones to tell you that most physicians don't understand sleep or airway either because they're not learning it. So it's a challenge, but you got to just be persistent and keep meeting with people and calling people and don't settle. I mean, I've had people come back to me in the residency and say, what does an orthodontist know about sleep?
Right.
They don't need anything. What does an orthodontist know about this? They don't know anything. And it's hard. I mean, so I've been there. But you just have to educate the parent and let them know, like, this is why I'm concerned. And then most parents will be like, okay, then I'll get a second opinion. Once you educate the parent, they become the advocate. And so it's a combination of you fighting to find people and educating your parents as to why this is important.
To address a little bit of the risk and that fear, I believe it was 5, fear of liability. A good question came up is, Dr. Richter says, I don't understand what the risk would be with early expansion. More than likely going to have to do it later anyway. So what could the risks be? I am new to this and wondering what risk I can inform patient when I do the consults. Like, what is the risk for early intervention?
The risk is you're going to have a colleague who doesn't think you should be doing it. Mm-hmm. That's the risk. And that colleague is going to call State Board, Office of the Professions, or if that parent, if something goes wrong, I've seen it too, something goes wrong with your early expansion because things happen, right? And things happen, and it's not a perfect profession or science, and nothing is. And they go for another opinion, and you have a colleague tell them they went in on you at 5. That's malpractice. I've seen it all. So I'm not being evasive in answering the question. My point is you're not doing anything that you are liable for as long as you're doing it appropriately and responsibly, right? I mean, if you do it incorrectly, that we're going to assume that you're doing it correctly, or you're not over treating or doing something they don't need, but we're going to assume that all that's acceptable. That's why to this point, I've never heard anybody whoever lost a case or was ever convicted of any malpractice, had to settle, or was ever held accountable in front of a board. And I've known multiple people who have been taken for their state boards. It's because someone's going to not like what you're doing. Mm-hmm. Does that answer it, Lauren? Do you think?
Yeah, I think it does. And I think also it's so hard to answer in like one question. That's why there's so many podcasts, there's so many conversations, there's so many things to really understand the benefits of it. But I like that kind of side. Well, what are the risks? And maybe that's a good conversation, if, to kind of elaborate on further. What are the risks?
That's a great point. And one thing I'll add to it is that's why you need to go back to what I said before. You got to do your homework and be educated, because if you have that happen and you're like, well, because you're going to come up against an orthodontist who's going to say there's no literature on this. You're going to come up against an orthodontist and say this isn't evidence-based. If you don't understand what you're doing and why, now you might be in a little bit of trouble, even if what you're doing is totally right. You have to have the knowledge. You have to be able to go in there and say, well, look, I took a CBCT. I detected they had this, this, and this. I looked at the coronal slice, and they have a transverse deficiency with rolled in lower molars and a narrow maxilla. So yes, I know they didn't have a crossbite, but I went in and uprated the lower teeth and expanded the upper arch. You start to speak like that, and as a result, the outcome measures show that the patient had this outcome and this outcome. You're going to really make it so that you're not going to have liability exposure. But that it's no different than what we know for anything. Like whether you're doing general restorative dentistry or pediatric dentistry or ortho, if you don't understand what you're doing and someone were to try to hold you liable and you go in, you're like, well, I did that because, I kind of thought they needed a crown, or, yeah, I thought that needed a pulpotomy, but like, the tooth was kind of symptomatic. You've got to say, like, this is what I presented with on the radiograph. This were the clinical symptoms, and this was my treatment. And no one expects every treatment to go perfectly. They expect you to be competent. And if you are a non-orthodontist, you are held to the standard of an orthodontist. The AAO is trying to dissuade people from teaching non-orthodontists how to do this. They put out a statement a few months ago, and I did reply to them about it. Yeah, I replied to them, and I had a back and forth with their lawyer about it. But it was clearly a shot across the bow to any orthodontists, me being one of them, who teaches non-orthodontists how to approach patient care. And basically, I got them to admit to me in writing that, yes, even orthodontists teaching orthodontists have a similar liability. Because I said it's all about whether or not the person's competent. It doesn't matter if I'm teaching an ortho or a non-ortho. If we're all held to the same standard of care. So you need to make sure you're educated. You can't just go in there and start being like, I do airway or I promote airway, and just start trying to throw treatment appliances at people because you've heard they might work. You've got to understand. You have such great courses, Lauren, with AHS and so much content. There's so much out there. You've got to start to learn this stuff before you just go do it.
Specifically with ENTs, is there anything you recommend, any webinars, any particular podcasts that you recommend to get an ENT on board, or just more curious?
I've had a few on my show. There was one really great episode that would help people a lot for how to speak to the ENT, with Peter Catalano. It was about 2 months ago, or well, if someone's watching this on replay, it was, I think, December 2025 was when Peter came out. That one was really great. And Peter's an ENT who has fought a lot of fights, as I have on this, in the orthodontic world, and really well received. So that's a great one. I've had David McIntosh. David McIntosh, you can look him up online too. He's in Australia. He's got a lot of great content that is geared towards patient and parent education on why treating early is important. And I don't know of a specific show that is done by or focuses on ENTs. I try to get a bunch on my show, but it's the same problem of trying to get an ENT in your community to do it. There's not a lot of ENTs. And again, it comes down to money. You hear it from them all the time. They don't make a lot of money to do tonsils and adenoids on young kids. Lauren, I've heard estimates where they make like $150 to $300 for tonsillectomy surgery. Like, I mean, what? And so they're going to take that liability and put a 6-year-old under. Again, it's tough. So it's hard to get to work with ENTs, but don't forget about your allergists. The nose is so important. We get so caught up in ENT world. I'm not saying we don't have to work with our otolaryngology colleagues. Don't forget about your allergists. Allergic rhinitis affects this. The American Institute of Allergy and Immunology reports that allergic rhinitis affects somewhere approximately 40% of patients. 40%. And there's been studies that show of that 40%, 80% of those patients have turbinate hypertrophy, so inflammation of the nasal turbinates, which means they can't breathe well through their nose. So we need to get these patients doing better nasal hygiene. We need to get them to an allergist so we can detect these issues. You can do anything you want. You can remove the adenoids. You can expand them. If they can't breathe through, you can do some type of guidance appliance. If they can't breathe through their nose, what are you going to do, right? And that's why, again, that's why you need the education to understand that. So don't forget about the allergists. A lot of times this is underlying allergies, as much or more as it is a lymphoid tissue problem.
Perfect. And also we have Dr. Jahandran. That was a great archived conversation. And we have now Dr. Stanley Liu on faculty with Camp Katwa. They have a great course coming up that I would highly recommend sharing that with your medical colleagues as well. But I just want to make sure that we have some updates here from AHS too, because I want to get to the raffle, and I just wanted to allow as many questions as we could because it's such an interesting topic. We'll probably have you back again to the fat a little bit more, because I know I love getting into it a little bit deeper with you, but the time goes by so quickly when you're having fun. But I just wanted to mention that Airway Palooza is actually being launched to our alumni and to the Breathe and Thrive attendees from the last conference. We are combining conferences for 2027, so we're really excited about that. And we are extending this VIP earliest bird special to our listeners tonight. So this will be the steepest savings, $500 off the tickets. And we're also introducing Myopalooza. So that'll be Thursday, the day before, full day of just Myo. And we will have the the Breathe and Thrive, the American Laser Study Club workshop alongside the Myopalooza. So we're going to have a third day of Palooza with more instructors. We have top-notch instructors and speakers, including Dr. DeLuke. I'm really excited for your presentation, but I will announce our keynotes. They're all keynotes, so we really have a great lineup for you, but just wanted to give a little sneak preview and some appreciation that we're extending this offer, not only to our alumni and past attendees, but to everyone this evening. So the code is early VIP, and you can learn more and see some of the video footage from Airway Palooza 23, 25. And Dr. DeLuke, I know it was your first Palooza. You want to comment a little bit on your experience there?
Oh, it's so great. It was such a great event. I told you then, Lauren, I mean it. I don't know how you do it, how you pull it off. It really is top notch. I go to a lot of meetings. I speak at a lot of meetings. And there's just a vibe there. There's a general sense amongst the attendees and the speakers that we're all part of a bigger cause at that meeting. And it was palpable. It was really the energy afterwards. We spoke a little bit after. It was like we both there's like a high you're on after that meeting.
Right.
That just creates, and it's nice, especially for people like me who I deal with fighting a lot of people who don't think like me. I will be speaking shortly at the Florida Association of Orthodontists meeting, which is huge. That I was asked to be one of their main speakers. They've gotten some negative feedback for doing that, but
they're going to do the DeLuke dip. They're going to do that
right.
DeLuke dip.
But that's a much different experience than it is in front of a group like the Airway Health Solutions, where you really share a lot of the ideas. You're not fighting uphill, so to speak. You can really you're at the top of the hill and you're trying to see further and see across the horizon, whereas a lot of times it's a fight. And that's just one thing that was so cool about that meeting, was the camaraderie.
Thank you. Yeah, I'm super excited for it, and everything's under one roof. So check it out and stay tuned for more information on our speakers as well. I do want to let us know we're welcoming a lot of new faculty onto Airway Health Solutions. We do have our base courses that starts with Dr. Ben Moralia. You can all go to our website, and then we have Dr. Kevin Boyd on the early childhood, ages 2 to 6. But I do really want to focus on our new courses that we have, which Dr. Pia Gandhi just did an amazing job. It's available on demand, about integrating laser tongue tie releases into pediatric sleep dentistry. That is available. And this is not like a teaching you how to do this. So we recommend going to the Breathe Institute or Richard Baxter's course, but this is a follow-up on, okay, I took the course, now what? So she's really a mastermind in marketing and implementing. So we thought this was a nice solution to add to our Airway Health Solutions catalog. We also have integrating soft tissue laser therapy for the adults with Dr. Andrew Cohen. This is on demand, and you can learn new techniques. Perhaps patients don't want to say yes to ortho. Perhaps they don't want to do any treatment, but maybe they'll do the soft tissue laser therapy, and it can help them. So you can start where patients are. Dr. Cohen does a great job at showing that. And also, I think it's really important to have great photographs. So Dr. Cohen really introduced me to the importance of having great photographs to help you with your co-diagnoses and to have your treatment plans really buttoned up and to hopefully publish one day. So I think this is a great course for all of your dentistry. So I wanted to put this on the Airway Health Solutions map, and Dr. Andrew Cohen did a great job. So this is available on demand, and it will help you with your case presentation as well. I know you just had Dr. Matla. You're releasing the podcast tomorrow, right? So
yep, Thursday. Yep.
Okay. So tomorrow, Dr. Mary Matlow, maybe you can tell us a little bit about like a preview, pre-sneak of your conversation, because we're thrilled to have her on faculty here. She'll be helping us with the full mouth reconstruction. And like you said, it's really not about the appliance, but she does happen to really, she's the creator, inventor of the Myo aligner. It's FDA approved. So maybe we can kind of both brag about Dr. Matlow one sitting here.
Yeah, we had a great talk about the concept of TMD and how it's unrecognized in the neuromuscular component of us not understanding it, really, especially in ortho. We had a great conversation about the fact that we go in and treat a lot of these cases, and we just don't know where we're even treating them to. We are just, they may be in a compensatory position and we don't know it. And that's why a lot of our cases get out of control. And you see, especially in adult complicated cases, all of a sudden you're chasing the bite. You can't get things to fit together. They're better one visit. Next visit, they come in different spot. Well, why? You get back to the diagnosis. You didn't detect some of that neuromuscular compensation that was built in because of the temporomandibular disorder. And it might have been a little bit subclinical. Patient might not have been symptomatic, and that can lead to a myriad of problems. So we got into a great discussion on the importance of the diagnostics and then what she can do with myoliner and some of the equilibrate or some of the neuromuscular compensatory, the LFT10s. And it was neat. It was an in-depth conversation. It's not a conversation about just myoliner. Really, we didn't even talk to myoliner till kind of the end. It was really just a conversation of a general practitioner who has a long history in restorative dentistry and saw a lot of breakdown in her cases happening and wondered why. And myself as an orthodontist having just a really nice back and forth on how we can be better providers.
So looking forward to that podcast, and we're really looking forward to having Dr. Motlow on faculty. And then also, this is a great course, as I was saying, it's coming up in March with Dr. Stanley Liu and Dr. Umakant Katwa. And this is great for your medical colleagues as well. So I think, Dr. Holler, you asked the question, this would be a wonderful course to take. And we do give year access. So you may want to share like a lunch and learn or take snippets from it and share it with your medical colleagues, because you have no better resources than Dr. Katwa and Dr. Liu. And also, you can just go to the website to get more information. I just want to let everyone know that these new courses are coming, and they're here to be part of your solutions in your journey. So Dr. Schwibner, Jenna Schwibner, she's actually an alumni of ours, and she took our coursework in 2020, and now she's basically airway only. She's also a student of Dr. DeLuke's. We recommend taking multiple courses from multiple companies. There's not just one way to do things. So you can incorporate and do your own go your own way, like Fleetwood Mac. So Jenna Schwibner just did that. She's taken the courses from everybody, and now she has a great implementation course. So we think this is another great solution to add. And that'll be April 10th and April 24th. We're also introducing metabolic health and circadian health with Dr. Andrew Cohen. So we'll probably do another conversation on that to get a little bit more background info. But we have our Myo courses. Everyone knows Brittany Murphy by now. If you're a myofunctional therapist, we have our business success course, as well as our electives of mini myology, and then also mastering tongue tie readiness. And I always like to give a shout out for upcoming conferences. My friend, Dr. Jerry Simmons, his SEC conference is going to be April 23rd and 25th in Houston. And actually the AAPMD Collaborative Cures is going to be in second week in May also. So check out the AAPMD Collaboration Cures in Pittsburgh. And let's do our raffle. So I'm going to stop sharing here, I think, if I can. Let me just see. Let me stop sharing.
Yeah, I can stop on mine if you want.
I think it's me. Okay, let me see if stop sharing. Okay, there we go. Okay, so this is the fun part. We're going to raffle off an introductory to airway fundamentals course. Everyone can benefit from this. So let's see who's our lucky winner tonight. Scott Niche. Okay. So Scott, Dr. Niche or Scott, we are happy to provide this for you. We'll reach out to you, and I'm just always thrilled. This never gets old. I can do these conversations just as long as everyone keeps showing up. And Dr. DeLuke, thank you so much for being such a pioneer and a pillar. And I'm going to think of the DeLuke dip. Just do the DeLuke dip and get in there. Start where you are. Mm-hmm. Forget about the bell. It's not worth it. It's just do your part, keep going, and keep bringing joy to your patients, and you'll be rewarded. And this will all come around. And great. I do think we have the paradigm shift. It's shifting. So let's keep the shift moving. Any closing words, Dr. DeLuke?
No, you said it beautifully. Thank you so much for having me, and always happy to be on with you and your group. Thank you for all you guys are doing as well. It's always a pleasure.
Okay. Stay tuned and tune into the Doc podcast tomorrow. I'm excited for Dr. Motlow's interview. Good night, everyone.
Awesome.
Thanks for being here.